hundreds of papers on causal inference, and he also recently have a book on causal inference. And Dr. Hernan's research addressed both the theoretical issue in causal inference and also applies those methods to healthcare application, including the optimal use of therapy for HIV and intervention for other cardio diseases. So without further ado, I will pass the time to Dr. Hernan now, and we look forward to hearing your tutorial. Thank you.
Thank you very much, Benji. So we're going to be talking about causal inference today, and because causal inference and decision making are really twin brothers here. We need causal inference to make good decisions. So one way of thinking about causal inference is thinking about the set of methodologies that we use to determine what works, that we apply to data to determine what works. And we have less than 90 minutes today. Of course, there is no time to talk in detail about sophisticated statistical methods for causal inference in complex cases with time-varying treatments and time-varying confounders, etc. So I'm not going to even try. The tutorial today is going to have no math. It's going to be conceptual, because that's really what matters. The technical parts are the easy one. It's really the conceptual issues where causal inference is hard. And you see that this is hard when you see maybe a decade ago when we were listening to the big tech companies, Google, Amazon, and all the others telling us that if we had a lot of data, then we could do causal inference. And of course, that is not how it works. You can have lots of data, the best algorithms, and still not be able to make reasonable causal inference, because they were missing the conceptual parts. They thought that there was simply an issue of applying good machine learning to data, and that's not how it works. So that is really the point that I'm going to be making here more, and I'm going to be using some examples to show you what is involved in making causal inferences from data. So causal inference is about deciding what works. Why do we want to know what works? Well, again, because we had to make decisions. In clinical medicine, where I do a lot of my research, there are decisions every day. Do we treat this patient with treatment A or with treatment B? Do we treat them now or do we wait? Do we switch the treatment to these patients because it's not working or have side effects? Do you treat all the patients with this disease or only some of them? So, and the same in the public health context, where I also work. Do we start a vaccination program now? And if so, for what age groups and how many doses? And those are all decisions that we have to make in public health. So any decision making needs to be guided by good inferences about the comparative effectiveness and the comparative safety of the different courses of action that we have in front of us. And in science, there is a very relatively simple way to know how what works or what harms if we are worried about safety, which is conducting a randomized experiment. Any scientist, you ask them, do you want how do you determine whether this treatment works? They say, do a randomized experiment. And a randomized experiment, when we do it in humans, is known as a randomized trial. So for human health, which is the focus of my research, in principle, we could do a randomized trial for any experiment, for any question that we may have about comparative effectiveness and safety. In practice, of course, that is not possible. There are some randomized trials that are never going to be done because they're so expensive that we are not going to be able to afford them, Others are not ethical. We want to know whether cigarette smoking has an effect on cancer. Well, we are not going to be able to randomize people to cigarette smoking. Others are not practical. If we want to know what is the effect of eating fish 3 times per week over 20 years, we're not going to be able to do a randomized trial. We're not going to convince hundreds of thousands of people to eat fish 3 times per week for 20 years. It's not going to happen. Or if we want to know whether the COVID vaccine has certain side effects, we're not going to be able to conduct a randomized trial of the COVID vaccine in millions of people now, which means that millions of people are going to be randomized to no vaccine. It's just not possible. But even when we can do the randomized trials, there would be a period of time during which we are waiting for the results of the trial. From the time that we decide we're going to design a randomized trial to the time that the evidence from the trial is there, maybe months, years. And think of what we do for the screening of colon cancer, right? Colon cancer, everyone age 50 and older is supposed to have a colonoscopy, and then every 10 years. Is that based on a randomized trial? No. The trials are not finished yet. They were started many years ago, 10, 15 years ago. They will finish in the next few years. But in the meanwhile, we need to make decisions. So it's great that we have this scientific tool that is a randomized experiment, because it will help us in some cases. But not in all cases, and even in the cases where this is going to help us, it's not going to help us now. We'll have to wait. And in the meantime, we still need to make those decisions. As a society, as doctors, as patients, we cannot say, oh, I'm not going to make a decision until the results from the randomized trial are ready, because not making a decision is making a decision, right? So that's why a lot of the decisions that we make are based on causal inference from observational data, because it's the only thing that we have. If we want to make decisions about health and we don't have a randomized trial, we have data that is non-experimental, data that is not generated as part of a randomized experiment. And there are 2 big beams of observational data. We have observational data that has been collected specifically for research. Someone has designed the data collection, which data items, features we are going to collect, and how we are going to collect them, and probably even how we are going to analyze this data. And that's the data that is collected as part of large cohort studies, epidemiologic studies, biobanks, that type of thing. And then there is many more data sets that are not like that. It is observational data in which we just happen to find it. It is there for us to use if we want for research, but it wasn't collected for research. It wasn't designed for research. Electronic medical records, administrative insurance claims, all that type of stuff, databases in millions or hundreds of millions of people that we may want to use. That is what is now known as real world data, or that's a new buzzword. So a lot of our research will be based on this data, on this found data. That is there is not research data, is not research grade quality data. The point that I'm making here is that we analyze observational data because we cannot conduct a randomized trial. So that is the problem that we have to deal with. We need to make decisions about health in this case. We don't have randomized trials. We still need to make those decisions. So we need to use observational data, and we need to use it in the best possible way. And that is what causal inference from observational data is all about. And unfortunately, this is not something we just put the data in an algorithm and we get the answer. It doesn't work that way. So even though we don't want to, not necessarily want to do observational analysis, but it's the only thing that we can do. But see, we can always think for each observational analysis that we do for causal inference, we can think of what would be the randomized trial that we would prefer to have if we could. Because that randomized trial is the target of our causal inference. That is what we really would like to have. And so that is something that we refer to as the target trial. The target trial is the hypothetical randomized trial that we would like to conduct to provide the causal inferences that we need to make or to support our decisions. So any causal analysis of observational data can then be viewed as an attempt to emulate that target trial. That's really what causal inference from observational data is all about. We know how to make causal inferences if we have randomization. And we have an ideal randomized trial. There is no technical difficulties there. Okay, the whole point is take our observational data and try to use it to mimic that hypothetical randomized trial as close as possible, our target trial. In fact, we can go further. If we are asking a causal question that we are ready to try to answer using observational data, and we cannot specify what the target trial is, we don't have a good question. We have no idea about what we are trying to estimate. And this concept of a target trial has a long history in science. In the 1950s, Dorn at NIH was talking already about the need to estimate, to use the observational data to try to mimic a randomized experiment. And Bill Cochran in the 60s at Harvard, Rubin also at Harvard in the 70s, Al Feinstein at Yale, Phil Davitt at Cambridge. All these people were thinking about this concept of a target trial. They were not using that name, though, but it was the same idea. We have observational data. We need to make it look like a trial as soon as possible. But they all were thinking in very simple terms. They were thinking in settings in which the decision is, do I treat or not, period. So I have a treatment is yes, no, now. But in practice, that's not the type of decisions that we have to make. I mean, think of the decision for a doctor. Is, do I treat this paper with this treatment, yes or no? Then after the treatment has been initiated, what happens if it is not working well? Do I increase the dose, yes, no? And what happens if there are side effects? Should I switch to this other treatment? And what if the patient becomes pregnant? The type of questions that we ask in real life are about strategies that are sustained over time, not just yes, no questions. And we had a theory of causal inference from observational data for sustained treatment strategies with time-varying treatments, time-varying confounders, when Jamie Robbins in '96 published his seminal paper. So that's really the type of, that is the framework that we work with today, is the framework of Robbins' causal inference from observational data for very complex questions. But causal inference in itself, if we take a step back then, when we think about it in the context of a target trial, has only two steps. The first step is we need to ask the causal question. The second step is we have to answer the causal question. And it's very important to keep these two steps separate. Because if you are given a huge database of several million people, the first step is to ask the causal question, not to jump into the data and start doing analysis. And how do we ask the causal question? We designed a randomized trial. We designed the target trial. So that's the first thing that we do. For causal inference, we design a randomized experiment, even if we are never going to conduct it. Of course, in the second step, the first thing that we can do is to, if we could, now we could conduct the target trial that we have designed. And when we cannot do that, then we use observational data to emulate the target trial explicitly. And explicitly is the key word here. We have to be very explicit, as we will see now. And then we can worry about the type of analytics that we're going to be using. But that's secondary. The biggest problems of causal inference from observational data, the biggest failures, have nothing to do with not being sophisticated enough in the data analysis. The problems are that the question was not formulated correctly in the first place. That is really what I like to discuss today, giving you a few examples of how this is done and how it is not done, and you can see where the issues are. The punchline is going to be that you cannot make causal inferences without subject matter knowledge. That you really need to be able to combine all this sophisticated data analytics component with subject matter knowledge that tells you what the question is, what the target trial is. So when I say that we need to specify the protocol of a target trial, what I mean is really we need to write the protocol of a randomized trial, which is something that includes some basic elements like the eligibility criteria, who is going to be in the trial, the treatment strategies that we're going to compare, the different treatments and how they are given over time, how the treatments are going to be assigned to people in the trial, the start and the end of follow-up of the people, the outcomes that we're going to be looking at, the causal contrast is going to be an intention to treat effect, a per protocol effect, and the statistical analysis plan. If we write these things and we show it to other people, the other people know what our causal question is and how we're going to try to answer. If we cannot specify these things, and I'm going to show you some examples of attempts at causal inference where these things are not known, then we won't be able to make reasonable causal inferences. And then once we have this, we have written about this, then we just explicitly emulate each of those elements using the observational data that we have, if we can. All right, so that now this is important because, as I said, in the history of causal inference from observational data, the biggest screw-ups are because this process wasn't followed. And I'm going to give you a few examples. I don't know how many we will have time to, but just give you a few examples so you see how this process works. The first example that I'm going to give you is now a classic now, is the example of hormone therapy and coronary heart disease among post-menopausal women. For those of you who haven't heard about this before, a very brief summary. In the 1980s and 1990s, there was a number of observational studies that were published in top medical journals that found that women taking hormone therapy had a lower risk of heart disease than women not taking hormone therapy. About a 30% lower risk, hazard ratios of 0.7 or so. This led to changes in the use of these drugs. By the mid-90s, the American Heart Association was recommending the use of hormone therapy to prevent heart disease in women with risk factors. All right, then a randomized trial was done. And the randomized trial found apparently the opposite. The trial found that women assigned to hormone therapy had a 24% increase in the risk of heart disease compared with women assigned to placebo. And this was shocking. When this happened, it was shocking because everyone was convinced that hormone therapy was beneficial for the prevention of heart disease in women. And it kind of made sense, right? Women have a lower risk of heart disease than men, but after menopause, women have the risk of heart disease starts to go up. So give them the hormones that they don't have, and they will be back to the level that they had before. But it's not that simple, clearly. So this led to a lot of soul searching and thinking about what could have been wrong here, because we were trusting observational studies and they gave us the wrong answer. In fact, it's not very, I mean, you can do a back of the envelope calculation of how many women died or had heart disease because of this mistake, and it's not a small number. So let's talk a little bit about what happened here. The randomized trial was part of a large project known as the Women's Health Initiative, a $1 billion project funded by NIH. And this particular trial had about 8,000 women in its group. They were assigned to placebo or to randomized or to hormone therapy. And they were going to be followed for 8 years, but the average follow-up was only like 5.5 years. They have to stop the study because of the harm. And this is what the randomized study found. The overall hazard ratio was 1.23 or 1.24. It depends how you do the calculation. The lower limit of a 95% confidence interval was 0.99 or 1.01. Again, it depends how you do the calculation, but it doesn't matter. Neither for science nor for decision making. When this is going to be used for decision making, we don't make decisions based on an arbitrary cutoff. I know that some people, probably not in this audience, think that if something is, if the 95% confidence interval includes the null, then the results is not statistically significant, and therefore we shouldn't use it. But that's, of course, highly incorrect, because that confidence interval is telling us that values from 0.99 to 1.53 are very compatible with the data, but the most of the values in that range are above 1. So clearly, if that is evidence for something, it's for a harmful effect of hormone therapy, right? We don't put a cutoff point at 1 and suddenly things are very, very different. It's like if I go to buy a new shirt, and there is this shirt that is $99.99, and there is this shirt that is $100.01. I say, oh, it's a completely different price. I don't know what to do, right? So this is just about p-values and about statistical significance are going to be less and less important as scientists start to stop using these concepts, which are not scientific concepts, really. But in any case, here, most of the action was happening in the first 2 years. The first 2 years of follow-up, the increase in risk was 50%, hazard ratio of 1.5. And then, as time went by, the hazard ratio went down. And let me explain what I mean by that, because this is going to be important for what we're doing here. If you take the data from the randomized trial that gave us the truth, if you look at the first 2 years of follow-up only, then the hazard ratio is 1.5, 50% increase in risk. If you look at the data from years 2 to 5 only, meaning if we delete the first 2 years of follow-up from the data, and then we compare women assigned to hormone therapy and to placebo, but only from years 2 to 5, then the hazard ratio is 1.3. But if we delete the first 5 years on the data, and then we do the same comparison, then the hazard ratio is 0.67. So 30% lower risk of heart disease in women assigned to hormone therapy compared with women assigned to placebo. That is not causal, right? Once we delete the first 5 years of follow-up, what we are getting is not valid as the result of a randomized trial, which is why we don't delete the first 5 years of follow-up from our data. Because what is going on here? Well, most likely what is going on here is that during the first 5 years of follow-up, women assigned to hormone therapy who are susceptible to the effects of hormone therapy develop heart disease. So after 5 years, they are not in the data anymore. After 5 years, the women that we have in the hormone therapy group are these super women that doesn't matter what we throw at them, they don't develop heart disease. Those are the women in the hormone therapy group. But in the placebo group, women have not been subject to that selective pressure. So they are normal women that are having heart disease at their usual rate. So if we delete the first 5 years of follow-up, we compare super women who have survived for 5 years with normal women, and we find that the super women have a lower risk of heart disease. But that doesn't mean that hormone therapy works to reduce the risk of heart disease. It just means that we are doing something very, very wrong with the data. That's not how we compare things, right? It's just a bias. So that's not how the randomized trial was analyzed, of course. So there's a paper by, a very nice paper by Stanzurus and colleague who they showed how this selection bias can make the hazard ratio go below 1, even if hormone therapy doesn't prevent heart disease in any woman. So if you have a treatment like hormone therapy, that the only thing that it can do to a person is to either increase the risk of heart disease or nothing. There is no single person that benefits from taking it. If you delete the first 5 years of follow-up, you may still find a hazard ratio below 1. That's all bias, is the selection bias. Now, if you ask people why, so let's just keep this in mind because I am coming back to this issue with the trial later. The point is that the trial found an increased risk, 1.24 overall, 1.5 in the first 2 years, whereas the observational studies were finding a benefit. So why? There is one tempting answer that many people use, which is, well, observational studies were getting the wrong answer because they were observational, because treatment was not randomly assigned. And because people was not randomly assigned, women who took hormone therapy and women who didn't take hormone therapy were very different. Women who took hormone therapy, these are studies in the US in the 1980s, 90s. These are women that have better access to healthcare. That's why they get hormone therapy. They also get much better treatment to control their hypertension and their diabetes. There are also women who have better diet, more exercise. They're wealthier. So yeah, women on hormone therapy do better because they're different from women on non-hormone therapy. It's not the hormone therapy, it's everything else about their lives. That's the problem that we get when we don't randomly assign treatment. That's confounding. Confounding is what happens when all these other factors are not balanced between the two groups, and that's what we eliminate with randomization. Yeah, the problem with that explanation is that the epidemiologists who were conducting these studies were adjusting for all those factors, or for many of them. And things didn't change. They were still finding that women on hormone therapy had a lower risk than women on non-hormone therapy. So it's time to think of a different explanation, which is not lack of randomization. One possible explanation is that the question that was being asked in the observational studies was very different from the question that we would have asked in a randomized trial. The observational studies were not emulating a target trial. Think about, again, what the randomized trial did. The randomized trial with the correct answer of increased risk was comparing women assigned to hormone therapy and women assigned to placebo, to no hormone therapy. So women assigned to hormone therapy were women who essentially all of them took at least one pill. So the trial was effectively comparing women who initiated hormone therapy at baseline and women who didn't. Initiators versus non-initiators in an intention to treat analysis, and they found that initiators had a higher risk of heart disease. But that's not what the observational studies were doing. What the observational studies were doing was looking at the data, finding women who were taking hormone therapy and women who were not taking hormone therapy, and comparing them. And they found that women who were using hormone therapy had a lower risk. Using, not starting. They were not comparing women that were being assigned to hormone therapy and starting to take it. They were comparing women who have been using it for some time. Months, years. So what the observational studies were doing for practical purposes was deleting the first part of the follow-up of women on hormone therapy, which is exactly what we saw, that if we do that in the trial, we will never do it. But if we did it, then we find that these survivors, these super women, have a lower risk of heart disease than women not on hormone therapy, because they have survived a period on treatment. That's exactly what the randomized trials, what the observational studies were doing. And they were finding a hazard ratio of 0.7, which is exactly what you find in the trial if you do the wrong thing. If you think about this, there was no difference between the results of the randomized trials and the observational studies. They were all finding a hazard ratio of 0.7, a 30% lower risk in women who have been taking hormone therapy for a few years. But of course, that's not the question that we are interested in. And why isn't that the question? Because it doesn't help decision makers. And that's the most important thing about causal inference. If the question we're asking doesn't help decision makers, it's not a causal question, really. Think of what the question is here. If I say that I am a post-menopausal woman and I go to my doctor and I ask her, hey, I'm considering initiating hormone therapy, but I'm concerned about the possible risk of heart disease. Imagine, and my doctor tells me, well, there is this randomized trial that has compared women like you who start hormone therapy and women who don't, and yeah, women who start hormone therapy had a 24% increased risk of heart disease. And now I, as a decision maker, can use that information. But imagine that rather than that, what my doctor has is observational studies only, like these ones. And then she tells me, well, you know, if you start hormone therapy now, and you happen to survive the next 5 years, then we will know that you are one of these resilient women who don't develop heart disease, and you'll be okay. Hey, that sounds silly, right? Because that is exactly the type of comparison that the observational studies were doing. It's not the comparison that we are interested in, because it doesn't help decision makers. All right. So this begs the question, what if we take the observational data and we reanalyze it to emulate a target trial, to compare initiators versus non-initiators, as opposed to current users versus never users? Well, this is something that we did. We just defined the protocol of our trial, which was very similar to a trial that had already been conducted. And that's a summary of a protocol. I'm not going to read that. But essentially, we have each of the elements of the protocol of a target trial. We specify those. And now with the observational data, we try to mimic each of them. And there are some differences. One is that the only type of trial that we can emulate with observational data is a pragmatic trial, meaning a trial with no placebo group, a trial with no blinding, a trial with no intensive monitoring of people. Why? Because we're using data from the real world. And in the real world, there is no placebo. There is no blinding. Everybody knows the treatment that they're getting. And we cannot emulate a target trial in which patients are seen every month if in the real world they are seen every 6 months. And that's something to keep in mind. If we're making causal inferences from observational data, we have to keep our expectations in line. We're not going to be able to emulate ever a phase 3 randomized trial, placebo control, double-blinded, with a lot of emphasis put on adherence to the treatment and where the individuals are followed very closely. Now, when we're talking about causal inference from observational data, we're talking about a trial. There are many of these trials in which we randomize people to one treatment or the other. We follow them. We see them once in a while. We don't do much to enforce adherence, and then we find out what happens to them, maybe through their medical records. So that is the type of trial, or that is the type of randomized trial that is done very often to support this decision making in the real world, because we want to know how a treatment works within certain healthcare systems. So that is the type of trials that we can emulate with observational data. And that's what we did with the Nurses' Health Study, which is a large observational study out of Harvard, in which women, every 2 years, they receive a questionnaire and they self-report about any new diagnosis that they may have, or their lifestyle, diet, all things, and then all these diagnoses are, the self-reported diagnoses are confirmed through their medical records. And in this study, we mimic the eligibility criteria from the trial. We mimic the treatment strategies from the trial, assignment, initiation of either opposed estrogen therapy or no hormone therapy. The same outcome, coronary heart disease. And the randomized assignment. How do we emulate the randomized assignment, which of course didn't happen in the real world? Well, that is what confounding adjustment means. When people say, I am adjusting for confounders, what they mean is I'm trying to emulate the randomized assignment of the target trial. In fact, if we could adjust for all the confounders, there would be absolutely no difference between an observational study and a randomized trial, because the point of randomization is making sure that there is no confounding, because there is balance in risk factors between both groups. The problem with the observational data is that we never know if we are adjusting for all the important confounders. That's why we prefer a randomized trial over an observational study, other things being equal. But here, we're not talking about a situation where there is a choice. We're talking about a situation where we only have the observational data, so we need to adjust for confounders, which means that we need to know enough about hormone therapy and heart disease to be able to find the confounders and measure them and adjust for them. And this is the part where this becomes something that is not just an algorithmic issue. Because if there is a very important confounder here, we need to adjust for hypertension. Any human expert will know that if we don't have hypertension in our data set, we're not going to be able to estimate the effect without bias. But computers don't know they don't have hypertension. They will just choose variables for adjustment blindly without expert knowledge. And that is really the problem of causal inference. I can give you a database with 200 million people and 3,000 covariates. And we can use the best machine learning algorithm to somehow select which covariates we are going to adjust for. And after doing that, any doctor will say, oh, by the way, did you adjust for hypertension? Say, no. Oh, so it is all wrong. We need that human in the loop in the whole process. Another way of saying this is that we need experts who know what the target trial is and then know which variables should be balanced between both groups. And so that is what we did here. We had lots of variables in the nursery health study, and we adjusted for all those things. And after doing that, we had emulated a target trial, similar to the Women's Health Initiative randomized trial, except that it wasn't blinded, it wasn't placebo control. Women were younger in the observational data on average, and they started, and the follow-up was also longer. in the observational data. So this is, very quickly, this is what we found after doing that. In the first column, you have the results from the randomized trial that we have seen before. In the second column is the results from the observational study after we explicitly emulated a target trial. The first thing that you can see is that there is no indication of a lower risk of heart disease among women assigned to, among women starting hormone therapy. We have a hazard ratio now of 1.05, which is not comparable with the 1.23 because, as I told you, the follow-up was longer in the observational data. And because the overall hazard ratio is the weighted average of the time-varying hazard ratios. And we have seen how the hazard ratio becomes closer and closer to 0 as time goes by. We have to compare in comparable periods. So if we look at the first 2 years of follow-up, where the action was, in the randomized trial, there was a 50% increased risk. And in the observational data, a 40% increased risk. So not exactly the same, but pretty close. And see, if the observational estimates in the 1980s and 1990s had been the ones in the second column, nobody would have been shocked when the randomized trial is conducted and you find essentially the same. The problem was not the observational data, and that's my point. The problem wasn't the quality of the observational data. The problem was what we did with the observational data. Once we explicitly emulate a target trial, there are no shocking discrepancies. There are, as you can see there, very wide confidence intervals. The estimates are not precise, neither for the randomized trial nor for the observational study. The estimates have a very similar width of confidence intervals. But the point is that this wasn't because of lack of randomization. There was a problem. The observational studies were wrong, but not because they were observational, not because the treatment had not been randomized, because there was enough data in the observational studies to adjust for confounding. The problem was that we were not even trying to mimic a truly randomized trial, so we made mistakes like this. But this is a study in which we have very high quality data because we were working with this research data carefully collected every 2 years by a team of investigators at the nursing health study. The question is, can we do this type of things when we are working with found data, with data from electronic health records, data that have not been designed for research? And that is going to be my second example. But before that, I've been asked to give some time for questions, right?
We can take questions from both the in-person attendees. Yeah, Siva, you want to go ahead?
Yeah. Okay. So my question is about, I don't know how to frame this question, but if we think of the case study that you presented, so having known that the initiation was the problem after the randomized control studies, you went back and looked at the observational data and then made sure that problem did not arise and then got the same conclusion. So this is like looking at it in hindsight, right? So if there is a new experiment, new case study, then how would I know what issue? Is it initiation, or it could be one of a million possible issues, right? We're not talking about confounders here. These are like, I don't know what these issues are called. So how would one like preemptively not make these mistakes?
That is an excellent question. Of course, I am using these examples here in which we know the right answer to make my points, to convey the message. But in practice, after we have learned this, the question is exactly what you have asked, is how do we know? We're not going to have time today to go over other examples that are the opposite. We do the observational analysis first, and then the trials. And the trials confirm what we have in the trial. In fact, it is really hard. And I'm going to say something that may be surprising to some of you. It's really hard to find examples in which correctly conducted observational analysis were not confirmed by trials later. It's really hard. But in the cases where it doesn't happen, as you are saying, we need to find a way to try to, the question is, how do we know that we're right when we are doing it? And there is a number of things that we can do. I'll talk a little bit about some of them later. But of course, one is making sure that we talk with the subject matter expert and say, what are the confounders here? Tell us. Because if we're missing some confounder, we know that this is going to be wrong. Second, we can look for negative controls. We can find results that we know are true. For example, we want to estimate the effect of this treatment on outcome A, but we know that the treatment has zero effect on outcome B. And the confounders for A and B are similar. Then we need to be able to show that we find zero effect for outcome B before we believe what we find for outcome A. There are a number of that type of games that we can do that are all based on expert knowledge. At the end of the day, we're never going to be sure. We're never going to be sure, but it's the best that we can do. Another thing is to think about the causal questions that we are answering with observational data, and I'll talk a little bit about this, as something that is not out in a vacuum, but there is a randomized trial that has answered some question, narrow question, and now we're going to expand about that, which means that first we need to benchmark our observational research, our observational estimates with the ones that we know from the trial. We are using the trial as a benchmark. Once we get there, okay, now we extend to different types of treatment or to different types of outcomes or to longer follow-up or to different types of patients. But first we benchmark. So there are different ways in which we can do this. The point is that this is not observational studies versus randomized trials, it's observational studies and randomized trials working together.
Got it. Thanks.
Any other questions? Go ahead and stand there.
Hi, maybe I can kind of ask a follow-up question on this. Is that, do you think it's kind of valuable to kind of, collect like as more as possible, like for data sets, kind of as, as a benchmark to verify like different causal inference method? Like what people do, like usually, for example, in CS, like for example, like ImageNet, like this type of like, collect like 1,000 data sets and kind of do verification for different methods to get a sense like which causal inference method works best. Like, yeah, do you have a comment on this?
Yes, that is something that we have done sometimes, but we need to define what a causal inference method is. Typically, when people talk about different causal inference methods, they mean different methods to adjust for confounding. So you can use propensity scores or instrumental variables, or you can use inverse probability weighting or G estimation. These are different methods to adjust for confounders. Mm-hmm. If we don't have the confounders, these methods don't work. Period. It doesn't matter. They are all going to be wrong. With the exception of instrumental variable estimation, which is a completely different type of method with other assumptions. But if we don't have the confounders, no methods work. If we have the confounders, if we have measured the confounders, then all the methods except for the G methods, inverse probability weighting, G estimation, and the G formula, are not going to work when the confounders are time varying. So we don't really need to check this. It's known from theory, it's known from simulations. If we have time varying treatments and time varying confounders, we need to use G methods. All the others, propensity score matching, all these things, they're not even well defined in that setting. So the question is not so much which causal inference method work best. We kind of know that. the question is, are we putting the right framework? And the right framework is, tell me what the target trial is. And that applies to every single causal inference that we want to make. If we don't know what the target trial is, then no method is going to help. And people use different words for this. Some people will tell you, I want you to give me a well-defined counterfactual contrast. That's the same thing as saying, tell me what your target trial is. So there are different ways of referring to the framing of the question and how to put there. And then the causal inference methods are secondary, typically, unless there is time-varying treatment and time-varying confounders. And then we need to go into G methods.
I see. Thank you very much.
Sure. Okay. So let's continue then. I was going to show you another example in which there were observational studies that failed, and you see what the problems are here. So just to give you two examples, and you can start to see the pattern here. This is so there are many observational studies that are published that have found an association between statins use and lower cancer risk. Statins are drugs that are used to lower the LDL cholesterol and therefore lower the risk of cardiovascular disease. But surprisingly, some studies have found that are also associated with a lower risk of cancer. And these are studies published in the best medical journal, in the top 10 medical journal, and the top 1. Sometimes they find that the risk is 50 or 65% lower. Not only this is surprising, this is wrong. We know that this is not true. If this were true, cancer incidence would have dropped in Western countries by half or more in the last couple of decades with the use of these drugs. If this were true, when we do meta-analysis of randomized trials of statins, we would find this same association, and we don't find it. There is nothing when we look at trials. They find nothing there. So why am I showing you this example? Well, because this example cannot be the result of compounding. Because when doctors give statins to patients, they give statins to patients with more risk factors for heart disease. So we expect to find a lot of compounding for the effect of statins on heart disease. But for the effect of statins on cancer, when doctors give these drugs, they don't know what the risk factors for cancer are for this. We don't know most of the risk factors for cancer. So even if they wanted, they couldn't do it. So this cannot be lack of randomization. It seems like from a cancer point of view, the statins are given essentially at random. So what we did was to use electronic health records from the UK to emulate a target trial of statins. And the first thing that we did, of course, was to define the protocol of the target trial. I'm not going to go into this in detail. Essentially, we just need people without a history of cancer assigned to either initiation of therapy or no initiation of therapy, and then followed for a number of years. And yeah, I'm going to jump to the results. This is what we found. What we found was no association with either cancer overall or particular types of cancer. The hazard ratio was close to 1, nothing. If we look at the absolute risk over time of the survival, is the same for people on statins and non-statins. And this is clearly very different from what these other studies published in top medical journals have found. So what's going on here? Let me give you an example of what's going on. We have written actually a couple of papers where we dissect, we do this post-mortem that you were talking about for some of these studies. And this is one of them. This is a study that found an odds ratio for lung cancer of 0.23. Right. Just think about what this means. It means that there is a serious medical journal that has published a paper that says that the risk of cancer in users of statins goes down by 77%. This is published. And it wasn't on the front page of all the newspapers. Yeah? So clearly they don't believe that this is true, because it is shocking. So how did this happen? We look in detail about the data analysis here, and we found two problems. The first problem, again, they were comparing people on statins who have been for some type of statins. Exactly the same as in the hormone therapy example. They were comparing prevalent users, current users. That is a very common problem. And that can create bias. But even worse, they were comparing people that have been using statins for more than 2 years, 4 years, sorry, versus non-users. But to be able to, if you have been using statins for more than 4 years in the follow-up, that means that all the cases that happen in those 4 years are lost. So this is a recipe for immortal time bias. In a truly randomized trial, we never decide, we decide which in each group at baseline, at the start of follow-up. We don't wait 4 years. And after 4 years, we decide who is in one group and who is in the other group. We don't use information from the future to classify people into one group or the other. That's what many observational analyses do. It turns out that if we do that with our own data, we also find hazard ratios of 0.2 or 0.3. But again, this is biased. Now it's doubly biased because of selection bias and because of immortal time bias. Let me explain what this means a little bit more. So, but before that, just focus on this. When people talk about observational studies, they criticize the fact that there is no randomization, that therefore there may be confounding. And confounding is, of course, a serious concern. But I've given you already 2 examples in which confounding, lack of randomization, had nothing to do with the problem of observational studies. The problem was different, was a different type of problem. It was the failure to handle information around time 0 of follow-up correctly. See? Think about a truly randomized trial. For each person, time 0 is the time of randomization. And that is the time where 3 things happen. The person meets the eligibility criteria. The person is assigned to a treatment strategy. And if there is an event, we start to count. We count it from that time. The same thing should be true in observational analysis. That time 0 is the time when those 3 things happen. See, in trials, we don't even think of it because it's natural. That is the time 0. But in observational data, we have to think about it. And we have to make sure that there is a synchronization of eligibility and assignment. Because if those 2 things are misaligned, we will get bias. Let me show you this with a picture. These are 4 examples of misalignment of A, assignment to treatment, and E, eligibility. So look at the second one, right? The second figure, you see the timeline and the T0, that's the time 0. And at time 0, we make sure that people are eligible. The E is at time 0. And this is the example of post-menopausal hormone therapy and coronary heart disease. Women were eligible at time 0, but the assignment to hormone therapy had happened before, years before. That's why the A is before. When that happens, we will have the type of selection bias that we've described. In the last one, in the 4th one at the bottom, you see the example of immortal time bias that we just discussed. At time 0, people meet the eligibility criteria, but now we look into the future to design which treatment group they are going to be in. And that creates bias. E and A should be both at time 0. So anytime that we are making causal inferences from observational data, we have to think first about how we emulate randomization, how we adjust for confounding. That's a very important thing. And two, how we specify time 0 and we decide who is, how people are assigned to one treatment or the other without using information from the past or from the future. So if we want to improve causal inference from observational data, the low-hanging fruit is thinking about putting time 0 in the right place. All right. Now, this doesn't mean the lack of randomization is not a problem. Of course, it is a problem because we can have confounding. What this means is that we first need to take care of all the other problems that have to do with time 0, because those are self-inflicted biases. Those biases don't have to happen. If they happen, it's because we are not using the data correctly. After we have taken care of that, now we can worry about confounding. Otherwise, we're never going to be able to adjust for all those biases, as in the examples that I show you. And I'm going to give you some, it's very important, what Siva was asking, it's very important to know what type of questions, what type of causal questions we cannot answer with a particular set of observational data. And that should be a very important line of research. You say, hey, you have that causal question, that question, don't even try with observational data, is not going to work. For that question, we need a randomized trial, period. So we've been trying to find those questions. I gave you a couple of examples. I could give you many, many more in which observational data were sufficient for causal inference. But there are other examples in which it is not. And what it is not is typically because of confounding. We try to estimate the effect of colonoscopy screening on the risk of colon cancer using claims data from Medicare. And it was beautiful. We found exactly what we are supposed, what you expect to find. We found how colonoscopy screening lowers the risk of colorectal cancer incidence. One of the largest trials on this will have some results next year, and we are looking forward to seeing what the trial says, because we are pretty sure it's going to be very similar to what we found. But if we do the exact same analysis, but we change the outcome from colorectal cancer incidence to death, disaster. Why? Because there is almost no confounding for the effect of colonoscopy screening on colon cancer incidence, because people who get the colonoscopy or not, they don't know what their risk of colon cancer is really. We don't know what our risk of colon cancer is. But it turns out that, so there is not much confounding. It turns out that people who get screened and people who don't have a very different risk of death, because there are incredibly complex socioeconomic factors that go into that, into who at age 50 in this country goes to a doctor and says, hey, I want some colonoscopy screen, or at age 65, because we were using data from Medicare. So impossible. We could not adjust for that. We were finding that the differences in mortality between those who get screening and those who don't are an order of magnitude bigger than the difference that you would expect based on the effect on colon cancer. So completely wrong. So that's something that if we are trying to estimate the effect of preventive measures using claims databases, we should quit. It's not possible. When the effect on total mortality is not possible. So when we found out about this, we wanted to publish it, so everybody knew, and then people would not waste their time like we had, saying, hey, this is the type of question that observational data is not going to work. And that raises another problem. It's extremely hard to publish. So we just submit a paper to a journal saying, we have found that there is intractable confounding for the effect of cancer screening on mortality. And the editor looks at us and say, okay, you are asking me to publish a paper that is wrong. So yeah, it's wrong, but we are saying that it's wrong. We are saying why it is wrong. Say, no, thank you. We could not publish it. And that, we believe this is a very important line of research. Tell us what doesn't work. And this should be public. It's very difficult to convince editors that this is something that they should publish. In fact, we ended up publishing by cheating, because they invited us to write a commentary of some related issue, and yeah, we put one paragraph on that, and then we put all the results that we have found. So we finally published it, but it's very hard to publish, and that's something that we need to change. We need to have some way for people to know what has been shown impossible to do with observational data. Let me, in the time that we have, let me go quickly over another example. Do I have time to go for another example? Yeah. This is more relevant. Is the COVID vaccine? See, just to show you how this works in the real, how this should work, and this is a very good example of how data had been used. There was, in 2020, there was a randomized trial to compare COVID vaccination versus no-COVID vaccination. And here I'm talking about the vaccine made by Pfizer BioNTech, but it's the same for the others. And this trial found that people assigned to vaccination have a lower risk of COVID-19, which is the reason why it received a urgency approval from the FDA, and the vaccination campaign started in December. The problem with that trial is that it was it's small, maybe 10,000 people. So very, very large trial, but very small to tell us what the effect of the vaccine is on severe outcomes, which are more rare, what the effect of the vaccine is by age group, what the effect of the vaccine is in pregnant women who were not even included in the trial, what the effect of the vaccine is for side effects that are rare, maybe happen in some groups only. Those are all causal questions that we need to make decisions, and they could not be answered by the trial. So we use observational data. In this case, we were working using data from Israel, from electronic health records from Israel, and the first step was to design a trial, which was very similar to the actual trial that had been done, and then we emulated it using the electronic health record. So that's the design of the trial, essentially people with a history of COVID, and we assign them to either vaccination or no vaccination. It is not placebo control, is not blinded. So after we have taken care of all these issues about time zero and emulation of the target trial, we still have a concern about confounding. Confounding is a very serious concern here, because people who get vaccinated are different from people who don't get vaccinated in terms of their risk of COVID-19. People who get vaccinated maybe have more healthy-seeking behaviors. They may wear masks. They may be more careful about lots of things. So we need to make sure that we are comparing people with similar risks. Otherwise, we may overestimate the effect of vaccination. Right? And so confounding is a very serious problem here. We had a huge database, millions of people, lots of variables. Which variables should we adjust for? Here, we did something which is similar to what I was describing before. We used information from the previous trial to benchmark. And how did we do that? Well, what you see in the randomized trial is that in the week or 12 days after vaccination, the vaccine has no effect, because there is a time until the immunity grows. So in the 10 days after vaccination, in the actual trial, the vaccinated and the unvaccinated have the same risk of COVID. They are being infected at the same rate. You only start to see the effect of the vaccine maybe 12, 14 days after vaccination. And from that time on, you see how the curves start to diverge. So we could use that. Because if in our observational study we find that the vaccinated and the unvaccinated have a different risk of infection from day 0, that means that the vaccinated are different from the non-vaccinated. But if their risk is the same in the first week or 12 days, then we know they're the same type of people. Because if they were different, their risks would be different. When I say different types of people, I mean different types of people with respect to their risk of infection. So this is what we did first. We adjusted, this was adjustment via matching, for age and sex only. And this is what we found. In the first, these are the first 21 days of follow-up. What we find is that the vaccinated, the blue line, have a lower risk of infection from day 1. That means there is compounding. We are not emulating randomization well. So we need to adjust for more things. And in fact, we ended up matching on very, very finely on things like the neighborhood where the person lives. Because people in different neighborhoods had first different exposures to infection, and 2 different use of the vaccination campaign. So after matching very finely on lots of things, then we got to a situation in which the curves were the same in the first 12 days, which is what we knew had to happen. After that, we are more ready to believe that what we find, what we are doing is a good emulation of the randomized assignment. This was the first evaluation of the vaccines with real-world data, where we did this. And so we did this with more than 500,000 people in each group, and we confirmed what the trial had found, a very high effectiveness of the vaccine for infection, but also we could study severe outcomes like hospitalization and severe disease and even death. We could look at those outcomes that in the trial had huge confidence intervals. So we now have a more precise estimate of that. And also we did this by age groups. Last week we published this for the same thing, but in the Delta period, which the trial didn't do. It was before Delta. So now we have estimates of effectiveness for Delta in different age groups, as I said, in pregnant women, etc. So this is really what causal inference should be all about. It's not about making these choices between randomized trials and observational studies. We can use the randomized trial to design better observational analysis. And sometimes we use the observational analysis to design better trials. It's really this, how these 2 different approaches to causal inference, they complement each other. But they only work when we use the observational data. This system only works when we use the observational data well, when we use it to explicitly emulate a target trial. And we can do some of the benchmarking that we were talking about. So to finish, when we think about observational data, causal inference from observational data, we have to think of these 2 steps. First, we have to ask the question. We need to know what the target trial is, specify the protocol of the target trial, and then we have to answer the question and either conduct the trial or use observational data to explicitly emulate the trial. Because if we don't do this, if we don't know what the target, where the target is, we don't know where we're shooting at. It's as simple as that. And there is a lot of confusion in the literature. And if you publish things in medical journals and other journals, many editors will tell you, well, if you are using observational data, you cannot use the word causal. You can only use the word association. So causal has become this dirty word that you cannot say. It's the C word. You don't say that because you are working with observational data. But the point is that even if I'm working with observational data, my goal, my scientific goal is causal. I am analyzing the observational data to generate evidence to support decision making. Therefore, I need to be able to explain that. I need to be able to explain that my goal is causal, because otherwise the analysis of the data that I'm doing doesn't make any sense. See, if I were only interested in the association between hormone therapy and heart disease, I would give you a 2-by-2 table of hormone therapy, yes, no, heart disease, yes, no. And that's it. And that would be my paper. But if I do that, the editor will say, no, you are not adjusting for confounding. Exactly. You want me to adjust for confounding because we have a causal goal in mind. So I'm not saying that we should write our paper saying, I've analyzed the observational data and this is the causal effect. No. I'm saying I'm trying to get to that causal effect. That's why I'm analyzing the data in this particular way. And what I get is my best guess for what the effect estimate is. It may be wrong, but it's the best guess. But this whole process requires that we are explicit about causal inference being the aim of our work. So I'm going to finish here. In the future, what is coming for causal inference from observational data in the future? Well, one, there are all these conceptual issues that are now they're now getting to the people that they should get little by little. This is not simply a data analysis problem. It's really a situation in which we need to combine good data analysts with good experts, subject matter experts. And that's how we are going to be able to do this. So this conceptual part of causal inference is now getting there. It wasn't there 10 years ago in a lot of fields, but now you see how the big tech companies, Google or Amazon, they are working with causal inference experts all the time. The last Nobel Prize in economics, which was given to people working on causal inference from observational data, those people are working with Amazon, and many other people are. So now, this is getting there now. We really need to think about this as well. But then there are some technical open questions, like how do we create information systems that can be queried quickly? Like, for example, these electronic health records that I show you from this data from Israel, where quickly you can use the data to answer questions that are important now. And that's something that not all countries have ready now. We need to have this, all these large databases need to be able to use in real time. One example here in the US is the VA, the data from the Veterans Administration, the healthcare records there. Those are updated nightly. So you can really use those data in real time, but that's not very common. We also need to make sure that the correct data analysis methods are used. And here, it's been a long battle of a few decades, but now I think it's clear that G methods are the methods that work for complex questions. People now understand that is taught, and we are seeing these methods used more and more. And finally, the big open question is, what is going to be the role of machine learning and artificial intelligence in all of this? Because Well, of course, the main problem is that what we call AI is not intelligence. If it were intelligence, it would be a different thing. But now we call AI to anything, essentially. But if it were really AI, if we could somehow make computers acquire the subject matter expert knowledge that they don't have now, that would change things. That would change things. So that's the critical point in the future, is when do we get computers that can emulate, they can design the target trial by themselves, as a human expert would do. And then they can emulate that target trial. And when that is going to happen, we don't know. I'm sure that it will happen at some point, at least within some settings. At that point, then we may not need humans for causal inference, but we are not there yet. And I'm going to stop here. Thank you. If there are questions, happy to take them. Yeah.
So my question might be a little bit too basic because I'm actually new to causal area. On the difference between association and causal that you just mentioned, the major outcome of association or statistical learning, methodology, is finding a function that relates. So the major outcome of these association machine learning or statistical learning technique, is actually the relationship or function that relates these variables with the outcome. But there are some side outcomes, right? For example, feature importance. So in the example of COVID, if we find a relationship between age, sex, which were confounders, and use observational data to actually find the association on the effectiveness of vaccination, if the importance of the variable is resulted, from this association, and we can make, conduct inferences on that. So isn't it the same as what we do with causal? Isn't the result would be the same because age and sex were already there, right? So it should reflect the importance kind of correctly and say that because the interaction between age and sex is also there. So my question might not be really clear, but I cannot distinguish, between these two situations and how the results might be different on the effectiveness.
Okay, let me try to answer that, and you tell me if I'm covering what you are interested in. So one possibility would be to say, well, look, because confounders are variables, and I'm simplifying a little bit here, but not much, because confounders are variables that are associated with the treatment and associated with the outcome. Let's just train an algorithm to find those variables in the data, and variables that are associated with the treatment and with the outcome, and now we adjust for those. There are two problems with that strategy. One is that major confounders may not even be in the data, and the algorithm doesn't know that. And two, confounders are associated with the treatment and the outcome, but all the variables that are not confounders are also associated with treatment and the outcome. And adjustment for those variables would introduce bias. And to distinguish between confounders associated with treatment and the outcome and other variables like colliders also associated with treatment and the outcome, you need expert knowledge. And the machines don't have that yet. So that is why it cannot be done as a statistical problem. Because the only way to choose correctly is if we know the causal structure. And as human experts, we may fail. We may think that we know it, and we fail. But at least there are many cases in which we know really what the causal structure is. So we may fail, but they are less prone to fail than just using it, doing it completely blindly.
Hi, I'm Brian Denton from University of Michigan. Thanks for a fascinating presentation. I'm curious about your thoughts on the role for latent variable models, like hidden Markov models, is there a role there to screen out for situations where doing an observational study would just add no value, or any thoughts around that? I'm interested in.
Well, there are many questions that are so complex that we may not have enough data observation. These are questions about whole systems, or questions about complicated interventions at the level of the society, or many other questions for which we are never going to have the data to emulate a target trial. So for those questions, we can do models, like Markov models. We can use these mathematical models that could combine data or parameters estimated from data with some assumptions about how the world is. So that's also a way of estimating a target trial, but it's not like a typical randomized trial. It's something bigger. It's something that we definitely cannot do. So we've talked about that, about how the more complex our question is, the more complex our causal question is, the more we have to get away from the data. So for a very simple question, do I treat with A or do I treat with B these patients over 1 year? We can do a randomized trial, and we have to make no assumptions. We just do that, and we get the answer. For more complicated questions, we are not going to be able to do the trial. We now need to do an observational study. And there we will have to make assumptions about no unmeasured confounding. And for even more complicated questions, for example, a question in the middle would be, what if people use stop cigarette smoking and age 50 versus not, or say that. There are no trials for that. We will do observational studies. But if the question is even more complex, like what would be the effect of lung cancer if we change taxes in the US in such a way that tobacco companies have to pay this that they didn't pay before? We don't have observational data for that. That is where mathematical models are going to be the best that we can do. Same, for example, we are talking about opioids. We can do trials for the effect of individual drugs. We can do observational studies to see how different patterns of use lead to different outcomes. But if we are talking about how are we going to fight the opioid epidemic in the US with different interventions at different levels of society, we are going to use models. And that's models is what we use for causal inference when we need many more assumptions that what we have just from data.
Thanks.
And
Hi, my name is Tian Yi, a PhD student from MIT. So I'm currently working on this causal machine learning field. And I think today's talk is very amazing to me, like mind-blowing. Like, I learned a lot. Thank you for the talk.
Thank you.
So I'm actually currently considering like the so-called causal inference in panel data. So maybe that's exactly what you said. It's like there are some confounders that we don't observe. But one way of thinking that in that world is that seems like we can assume some it's some assumption, but usually it's like a low rank assumption for the panel data you observe. In that case, kind of adjusted for to deal with the confoundedness issue. Yeah, so I'm curious, like, do you have a comment on that sort of how to think of the confounded issue, unobserved confounded issue in that panel data case?
I'm not sure I'm following what you're saying. If we have panel data, we may have collected data on many variables.
Right.
But there is no guarantee that the confounders are included unless we make an effort to get those data. So in the absence of confounders that are important, there is really nothing we can do except model the whole thing.
Exactly.
Right.
Exactly. So people kind of assume a few models to deal with this, such as like synthetic control, and kind of a similar method to this. And we also do kind of observe like it's very useful in practice of thinking this. Do you think that's kind of also one kind of direction in the sense of like assuming a model, but you try to kind of test it really in practice to
Right. One, and that has the flavor of the negative controls that I was talking about, although
right.
different thing. But the problem with those things are very hard to use for complex strategies. When the question is not treatment yes, no, which is 99% of the literature on causal inference, especially in the social sciences. But when the question is, do I start treatment now, continue to treat? If A happens, then I switch to this. If B happens, then I switch to that. And that's really the type of questions that in many fields are almost the only questions that we care about. And for that, there is really not simple way of dealing with that if we haven't measured the confounders over time.
I see. Thank you very much.
Okay, if there's no more questions, let's thank Professor Hernan again for this amazing talk. Thank you.
Thank you very much.